Hey everybody, welcome back. It's week 4 of our Every NICU is a Neuro-NICU series. And I hope you've been following along all month. If not, don't worry. You can go back to our channel and you can pick up any of the replays from earlier in the month. And definitely click the link in the show notes below so that you can get the workbook and the free nursing CEUs. So it is week 4. So let's do a quick recap of where we've been and the other sessions that you hopefully have seen. But if not, you can know which ones to go back and watch. This month, we have gone through what, why, and how to create a neuro-NICU. And I really believe every NICU is a neuro-NICU. And so I hope if you'll go back and you'll focus on week 1 where we really talk about the what and the why. And then we dive into the 4 pillars of neuro-NICU care. The 4 pillars are neuro-assessment, neuro-monitoring using things like aEEG and NIRS, and then last time we talked about neuroprotection, the things we can do to prevent a primary injury, and then this week is all about neurodevelopment. How do we nourish the neurons we have? If you haven't already, do me a favor, go ahead and click the subscribe button here on this page. It really helps us and it helps YouTube to know that you want to see more videos from us. So with that, I'll let you dive in and I'll see you at the end. Thank you all for joining again. This is exciting. What I thought I would do, I'm gonna share just a couple recaps from last week and to reorient us and recenter us for where we're headed today. So first off, my name is Kathy Randall. If we haven't met, I'm so happy to be spending some time with you today. And I do a lot of international consulting and working in different NICUs. I like to say I'm a freelance clinical nurse specialist these days. And I do consulting work at various hospitals who have neuro-NICU. So that's the way I spend most of my time. And today's webinar is being provided by Synapse Care. And of course, as always, this is an evolving area and we are going to talk about things that are not approved by the FDA and probably never will be, honestly, from the way our neuro-NICUs and our NICU practice has been in the past, right? Practically everything we do is off-label. So we went through what is a neuro-NICU, what are these 4 pillars of a neuro-NICU, and then really how to begin to think about making change in your NICU. And we're going to talk a lot more about that at the end, because I really do believe every NICU is a neuro-NICU, and depending on how you decide to implement that in your hospital, we can all do better. So just the overall objectives, again, is just a recap. We've already covered the why, this trend of why we have neuro-NICUs. What, we've talked about the 4 pillars of neuro-NICU care and some bedside practices. We're going to definitely dive into a lot of this today. And we focused on neuromonitoring and we did a lot about aEEG and how to read that. And then really the end of this, and really my biggest goal of having these online courses and doing presentations anywhere is really not to just share information, but to make sure that at the end of the day, you have a plan of something that you can do in your hospital so that you can make one small change. And I think every big change starts with small change. And so what's one little thing that you can do to maybe tweak something that you're doing and to really think about improving neurodevelopmental outcomes for babies? Let's dive in for a few minutes into nurturing these neurons that we have. And really talking about neurodevelopment. And again, we talked earlier about these critical windows of development, right? That we have these different segments of time that are like open and closed doors that we need to go through development. But I always like to think about the brain of our babies, our small babies, as going from the mushroom into a cauliflower. And all the things that need to happen so that that's a healthy, big, giant cauliflower brain, right? Instead of a smooth, undeveloped mushroom brain. All right. So some of the challenges that you guys mentioned were providing tummy time, noisy units, parents with social issues, loud visitors, and too much light. And I know that there are probably many, many more, but these were the ones that kind of came up over and over again. So what are these things that we can do to grow neurons, this neurogenesis that we can have? Well, there are lots of investigational things that we can do. EPO comes up again, stem cells comes up again, growth factors comes up again, just like when we were talking about preventing injury. But what we have now at our fingertips that we can use to really help with nurturing the brain are things that we probably don't even think about as actually creating developing brains. So massage, kangaroo care, and nutrition. These are all things that we provide every day in the NICU. So I love to talk about kangaroo care because I think we all agree that kangaroo care and skin-to-skin care is really important, that it's really important for bonding and breast milk production and temperature regulation. But until I started reading the literature around brain maturation, I didn't have any idea how actual skin-to-skin actually creates bigger, better brains. So what I love about this study is that they actually looked at kangaroo care a few hours, a few times a week, not even like what the Europeans do at 20 to 22 hours a day of kangaroo care every single day of the week. So this is American style kangaroo care, just a few hours, few times a week. But they also had better brain complexity. How crazy is that, right? Better brain complexity and more maturity on EEG. So just the overall EEG patterns were more mature, and on MRI, the brains were more mature. So the actual experience of having kangaroo care and skin-to-skin exposure actually changes the brain. Neonatal nutrition. I hope you guys are all laughing because this is so cute, right? I love those baby rolls. So what we know about neonatal nutrition is that growth of the body tracks growth of the brain, usually. And that optimal nutrition is neuroprotective, and that we need to have the right amounts of protein, the right amount of essential fatty acids. We know that the more mom's milk we get, it is better for the brain, right? Decreasing inflammation, decreasing our risk of NEC. We know all of these things, but these things impact the brain. And we don't always think about all these little things that we do every day and how they really do impact the brain. And the last bullet point here is infusion causes fat loss. And so I just want to show one slide here because I think it's really, really important. And then I think most of you are probably aware of this phenomenon of extrauterine growth restriction, which we know that up to 35% of babies in the NICU actually do have extrauterine, so post-birth neonatal growth restriction. And whether or not that's just the inability to keep up with their needs, or that we're just not quite yet ready to be able to optimize that nutrition with the kinds of therapies we have. So back to mother's milk and the importance of fat. I put this just funny little pyramid here, keto. So if any of you follow all the trends, right, everything's about the keto diet. But it's important to realize that, mommy's milk, mother's milk, is almost all fat. It is, the majority of it is fat. And that when we store it and we infuse it, we modify its composition. Mother's milk by design is high fat, then protein, and then very few carbs. It is very much a keto, it's like a keto diet. It is literally like a keto diet. But when we put it in plastic, we actually change its composition, and we actually may be partly causal for this extrauterine growth restriction that we see. So this is a really interesting study, and I'm not sure where the reference is, but if you need the reference, I can give it to you. Just email me. So let's look here at fresh frozen breast milk, 2.17 milligrams of fat. So 100% of the fat as it comes out of mom. Then they were pasteurizing it. That dropped that by about 6%. Then they froze it. That dropped it by another 2%. So after pasteurizing and freezing and thawing, we dropped it down from 100% to 92%. So about a 10% loss in fat. Then this particular study was looking at different types of methods for infusing, for actually infusing it. So then they looked at reference pumps. So this would be like a regular IV pump, and then you hooked it up to a syringe and you put a regular tubing into it and connect it to the feeding tube. Just by doing that, at the end, the breast milk percentage of fat dropped to 55%. So probably most of us have started inverting our IV pumps when we give breast milk, because then the fat will rise to the top of the syringe, or putting them on an angle of some sort so that it's skimming the milk in. So we want to make sure that we're giving that fat, right? Mom's milk is mostly fat. And if we're allowing that fat to settle at the top and we're not giving it, we're actually not giving what was intended. So inverting it improved it almost by 20%. So if you just give it, if you just keep your IV pump like this, then the fat's going to rise. Then the other parts of the milk components are going to go through, and the fat's left behind. Then if we invert it, at least we give some of it. And then this was actually an experimental one where it inverted it, and then it did some back and forth flow where it was churning it all the time so that it stayed a little bit more suspended. And they showed that that inversion and that flow actually improved 83%. So still almost a drop of 10% by giving that milk through the tubing. So I know that the kind of culture of the NICU and most NICUs that I visit, most people are putting feedings on a pump. There's gone are the days of holding a baby and holding their gavage tube and just pouring it into the syringe and allowing it to gravity feed in. I don't know if it's just been computer documentation that has stolen that time and that we no longer can give that, not even to talk about the other social benefits of holding a baby and the developmental benefits of that. But I think by putting this milk through this plastic tubing, we're also degrading the nutrition that we're providing, even though we may have fortified that milk in the syringe to a point we thought was optimal. We have to really recognize that the tools we're using may be interfering with that. So anyways, just food for thought. Okay, so those are just kind of the kind of last things to think about on the making neurogenesis happen. So now we're going to move into things that we can do to nurture the neurons that we have. So number one is minimizing stress and pain. This cannot be underscored and truly can be a 2 or 3 hour lecture just by itself, what stress and pain do to the brain. But just want to talk a little bit about some interventions that we can do at the bedside. But I think overall, we really just need to recognize that stress can actually alter brain development. And so we know that repeated stress has profound long-term lasting effects on the CNS, especially early periods of pain, and that these stressors are not always physical. So we talked about IV starts or heel sticks, and of course we can acknowledge that, but there are other kinds of stressors that our babies experience that we need to minimize. Anytime a baby has pain and stress, it elevates their stress hormones. It elevates their cortisol levels. We have babies who need hydrocortisone to maintain their blood pressure because they've gone into adrenal fatigue. They've gone into adrenal failure from that pain and that stress. So that disruption of that stress hormone system lasts for them for years and years to come. That kind of hypersensitive cortisol secretion actually continues. They've done studies on preemies at 7 years and 11 years, and their cortisol levels are still elevated that far out. So we disrupt that hypothalamus pituitary axis, the HPA axis from the brain to the adrenals. We disrupt this through this early pain. So physical pain, but the stress of psychological and social being separated from their mother is also very stressful. So Newman et al., including Dr. Ender as well as Luann Woodward, published this paper back in 2009. And I love this paper because it talks about measuring the stress that your babies go through on a daily basis. And it's about a 4-page tool. And for a research project, they were able to get people to do it. But they basically gave different stressful things in the unit scores. So you get a 5, a 4, there's also more, there's 3, there's 2. So on things that are 5, multiple attempts at starting an IV, intubation, insertion of chest tubes, eye exam, those are highly stressful. We all agree with that, right? Then there's very stressful, suctioning, removing a baby from the bed if they were unwrapped, number 4. Having a systemic infection, being on the jet vent without sedation, getting inserted IVs, having a PICC line placed. These are also very stressful. Moderately stressful. I don't know about you, but some babies, I would say moderately stressful, but they named these things. Being weighed, having an echo done, getting a gavage tube, putting in your prongs, just getting nasal CPAP, you got a score of 3. A little stressful, mouth care, sampling for blood, things like getting your IV fluids, having IV, just having an IV and tape on your skin in place. So what they did is they actually went, and you can see on this slide, they divided the time periods up from 2 hours. So 7 a.m. to 9, 9 to 11, 11 to 1, 1 to 3. And what they did is they actually wanted to see what were the stressor scores that babies had. So they did it as a quality improvement project. They also did it as a research project. And then they did several follow-up papers to this group did. And they then looked at what could they do to intervene so they could actually tell people this baby already has a score of 4, no more interventions. So I think there was like a cutoff. I can't remember exactly what it was. But they actually would say, they would track these scores, and then they would say, this baby's already had so many scores, we have to go. You have to wait until the next 2-hour period before we can stress this baby out again. So they actually looked at it. So I think it's a cool paper. It's really well written, super easy to understand. And they did several follow-ups. One of the follow-up studies that they looked at were the average daily neonatal stress score, and they looked at the size of the brain, the bifrontal diameter. And you'll notice that as the score went up this way, the actual size of the brain went down. See the trend line? So this is scatter plot, but you can see the trend line goes down. So there are babies who just having this high number of stressors, so not just surgery, but just high numbers of stressors would actually have smaller brains. So some interventions for pain. So we talked about using sucrose. I think we underuse, overuse, misuse sucrose. We'll talk a little bit about that at the end. But I also think we underuse maternal holding. And so there are several Cochrane reviews on this, some great articles, some great videos that help to teach us how to teach families to be with babies during painful experience. But breastfeeding, so you can see here, this is a summary from the Cochrane. Breastfeeding, when compared to placebo and no intervention, effectively reduced pain response associated with common puncture procedures in babies. So a decrease in heart rate, a decrease in cry, and a decrease in facial response. Maternal holding. So decreasing pain and stress, super important. Lots of different ways we can go after that. One of the other things we want to do a lot of is offer positive sensory experiences. So when we do negative things, so like we were just talking about those stressful things, can we do something positive to those babies as well? What can we do? Can we provide that hand hugging? Can we provide yummy mommy milk? Can we do things that are good? So painful sensory experience, positive. Something negative, something positive. What can we do to balance those sensory experiences? The other thing I want you to think about too is just the way that the nervous system develops. It's very systematic, right? From tactile system very, very early on to vestibular system, gustatory system, olfactory, auditory, and visual. It's very systematic, and babies are prepared at different times to be able to receive different kinds of sensory interventions. The other thing I want you to think about is just how mature some of these systems are even in our 24-weeker. So if they're not really ready to receive that stimulation, they're easily overwhelmed by it. They don't habituate to it like we do, but they also have a hard time even bringing it in. But when we talk about the tactile system, so if you're a 24-weeker, your tactile system is very mature. Your vestibular system, right? Your sense of order and motion at 24 weeks, it's very mature. So it can really be overly stimulated easily. And I love to show this picture of the Preemie Flip. This is back in the day when we used to flip babies really fast because we thought that faster was better, before we knew that we were just stressing babies out by actually overstimulating that vestibular system. That's how we now know that we should be offering very gentle, very slow movements, because we don't want to be overstimulating that vestibular system. The gustatory system, right? The taste. There are some gross tastes in the NICU, right? But we also know that there are some good tastes that we can offer babies. Things like colostrum, right? Colostrum oral care. We can do olfactory. There are lots of yucky smells in the NICU, but there are lots of things we can do to offer positive sensory input from the nose. Auditory input. I don't know if Sarah is on the call again this week, but Sarah Baki was on the call last week and she talked, so she was actually just did a presentation in Philadelphia last week where she was talking about her program and her NICU where they're actually doing baby bookworms, where they have volunteers reading to babies. So we know that language exposure improves language development. And so in her nursery, in order to take away some of the sensory deprivation, they're actually providing volunteers to read. Auditory stimulation, good auditory stimulation, not just sharp noises, sharp alarms, those kinds of things. And then visual, things that we can do visually when the babies are ready. So just keeping in mind that these systems are available and they're also can be easily overwhelmed. The other thing we can do to provide neuroprotection is really minimizing separation between parents and child. And this means that we provide early and uninterrupted skin-to-skin care, even in the C-section rooms. As long as we can see the baby's nose, as long as the baby's not in distress, we should be offering this. So even if we know we're gonna have to whisk the baby away in a little bit, how much can we provide? The more, the better, and the longer and more uninterrupted, the better as well. Babies who are removed from their mothers, so there's been a lot of primate studies, there have been other maternal separation studies done in animals because it's not ethical to do in humans, but we know that that actually changes brain chemistry and behavior long term. And so you can see from this little diagram here that we have maternal separation and that we see that the monkeys who are peer reared actually have altered brain serotonin function. And we know that serotonin is that happy hormone, and so they actually have decreased serotonin. They also have decreased activity, high negative emotionality. They're more jumpy, they're more jittery, they're more distrustful. Then as adolescents, they're more aggressive, they have less social competence, and then as adults, they have high stress as well as high alcohol consumption. Are you wondering how they measure that in monkeys? Yeah, me too. I don't know how they measure it. Well, I mean, they study it, but I don't know how. Do they just give them water and give them alcohol? I'm not quite sure how they do it, but certainly has a long-term effect, being separated from their moms. So anything we can do to reunite and reconnect babies with their moms really is to help them for their whole lifetime. We need to protect sleep. What we know when we have deprived sleep, we have deprived sensory systems, we have deprived and disrupted learning and memory, we have loss of cortical plasticity in our brain and smaller brain sizes. So we know that sleep, and especially getting those good sleep-wake cycles, are very important for our baby brains. And last but not least, things that we can do that really do help to develop a healthy brain and nurture those neurons is promoting those strong bonds between moms and dads and their babies. So I love some of the techniques that Kara Ann Weitzman teaches around parental provided massage and really being able to do a good massage program at your hospital. But a lot of our families, they're really having a hard time coping. And so in addition to providing some of those things like massage, we need to be providing more psych services for our families as well. So this is Danielle Fantis, and she actually has a huge Instagram account. And this was a picture that she posted about her and her family. And she really wanted to talk about, and she really does continue to talk about, the mask that our families put on to make us feel like everything is okay. And this is another picture that she posted. And this is like the reality picture, right? This is what I want everyone to think I'm doing. And this is the reality. We have many, many families who are falling apart underneath and who come to the NICU and put on that happy face for us. They want to be that good parent. They don't want us to know what a disaster they are. But what we know is that postpartum depression and other types of mental health issues, maternal mental health, is a big problem right after delivery. So depression is a common mental health diagnosis. treating moms results in better outcomes for babies. We need to recognize and identify this. What we want is that put together mom to come to the bedside, hang with us for a little bit, and then leave. We don't want to know about her mess. And I think that this is more our problem than her problem, and that we've not really addressed it, and we don't have the services in. And actually, if we start unraveling this, we need a lot more services, right? But some of the outcomes that we see when we actually address and talk about maternal mental health is improved toddler attachment, toddler temperament, and maternal parenting efficacy. They feel better about their abilities. So I think one of the things we have to realize is that mom's mental health affects babies' outcomes. And so because we care so much about the babies we care about, we have to care about this. The piece I didn't even talk about is PTSD and all of the post-traumatic stress disorder that goes into having a baby in the NICU. Some statistics from Dr. Shaw at Stanford would say that as many as 40 to 50% of parents have some level of PTSD after a NICU admission. This is another piece. That piece really plays into play because what happens is that after they go home, 2 months, 4 months, 6 months, even a year later, some of that stuff comes back to haunt them. And if we haven't given them the tools or the referrals, then they are out there on their own and they need help. So helping us to start to rethink this on maternal mental health is really important. Because in the end, we're trying to create bonds that last a lifetime. These neuro-NICU babies, these babies who have neuro injuries, they need parents that are 100% invested in them. They are complicated babies. They have many follow-ups. They have many appointments. They are challenging. And then there's that constant reminder of the loss of what they thought was going to be. And so we need to be sure that we're working towards creating a healthy, strong relationship between them and their babies. And so for us to realize that their mental health has an impact on our babies long-term, we have to find better programs for them. So I would love to hear if you guys are doing anything specifically for maternal mental health. And if you even get psych, we're getting more and more psych referrals now. We're giving more psych referrals. So as we think about these 4 pillars, the neuroassessment, the neuromonitoring, the neuroprotection, and the neurodevelopment, all of these 4 pillars go together. And at the end, when we talk a little bit about how you can take your next step forward, really you can choose any area. You can just move from where you are and you're going to move that needle just a little bit. And again, just picking something that you can work on really important now, and then something that you can work on maybe long-term. So something short-term, something long-term. And then you can get that investment. You can get people committed. You can get people engaged and really build that consistency like Kim was saying they've been struggling with. But it's hard work, the stuff that we're doing. So any questions about some of the kind of neurodevelopmental, like things that you can be doing differently? What are some of the things you guys are proud about in your unit? What are the things you guys are doing really well that you would love to show off about? I'd love to hear what you guys are doing. Nothing? No showing off? Well, you guys email me a lot, so I know you guys are all working on stuff. So I'm just being shy and modest today. Any questions? All right, I think what I'll do is I'm going to wrap up with kind of like what would be your next steps, and then we'll go into therapeutic hypothermia. Because I know not every unit is offering therapeutic hypothermia, and so part of the presentation that I made for therapeutic hypothermia does apply to everybody in every hospital, but then most of it is really the nitty-gritty of if you care for babies in the NICU that are undergoing cooling. So I want to make sure that everybody's time is well served and that I don't bore you with stuff that doesn't really apply to you, but I know the implementation stuff applies to everyone. So I'm going to go ahead and do that, and then we'll come back to hypothermia. Okay, so we talked about the why a neuro-NICU. We talked about what is a neuro-NICU, things that you could be doing, measuring, but then there's really the how, like how do we take it from where you are to where you're going? And so I do want to give you a few little ideas. And so last time when we were together, we talked about what is a neuro-NICU, and that sometimes people think it has to be a really formal program. But again, I'm saying every NICU is a neuro-NICU. So it can be a QI project. So it could be some of the things we've even talked about today. Kangaroo care, being more consistent, creating a culture of documentation, creating a better quality improvement project, program where people are actually getting the information and understanding what your stats are and how things are moving in the right direction or the wrong direction. It could be taking a program that you already have and expanding it. Maybe you've been offering passive cooling and transporting your babies, and now you're ready to start your own cooling program. Maybe you haven't started a neuromonitoring, but you're wanting to start neuromonitoring. So how are you going to start that? So expanding on what you're already doing. Sometimes neuro-NICUs are all about the physical space. So actually building a quieter unit, or a unit that actually supports families at the bedside, providing space for them. So it can be those kinds of things. It can also just be a project in which you try to change culture. And that's a long-term buy-in, right? Those are things that take years and years to take hold, but are worth the effort. So changing your unit from one that isn't providing consistent kangaroo care, or isn't providing consistent pain management, into one that is. So those are all things that I think we can do. So where do you go from here? Number one, I just was mentioning this, is pick your number one issue. Because I think if it's your number one, that you will have passion behind you. And that when you have passion, you can get through those highs and those low points. You can either do that, or you can just pick your easiest issue. Because sometimes a little bit of success builds momentum, and then you can begin to find those places where, you know, your unit is on fire and that you really want to work on those things. And I love this quote that says, small daily improvements are the key to staggering long-term results. And to just remember that small things make a big difference in the long run, right? Every little thing we do in the NICU, we know little things matter. So again, just for this kind of quality improvement, moving things forward, I just want to encourage you to pick an issue and then move on it. And then we talked about last time how the different domains of nursing practice, or just our overall NICU practice, are influenced by practice, personnel, equipment, and then just measuring that practice and seeing where you are and measuring how you want to get there. So remembering that as you attack something, that you might have to attack it from one angle, but you might have to attack it from multiple angles. So you might want to do a deep dive and make sure, okay, well, this kangaroo care issue, what's going on? Do we not have all the right personnel? So I think sometimes we just think, oh, we just need to send a memo and we just need to do more education. Sometimes I don't think we look at all the pieces. Maybe there's a practice problem. Maybe there's an environment problem. Maybe there's an equipment problem. Maybe people just don't understand the value. There could be a little bit of education, but I think sometimes we think it's all education. I love this quote from Robert Kennedy. Progress is a nice word, right? Don't we always want progress? But in order to have progress, change is its motivator, and change has enemies. So I love this, right? Progress is a nice word, but change is its motivator, and change has enemies. So we've got to make sure that we're thinking about that. So in the surveys, these were some of the top projects that you guys said you guys are working on. Q-based feedings, Q-based cares, NIDCAP, skin to skin and EEG problems, so some skin breakdown issues. Under protection, there were so many different things that you guys were working on. HIE, IVH, 5 people mentioned IVH prevention, infant massage, midline, neuroprotective bundle, NAS care, golden hour. And then for development, these were some of the other projects. Understanding development, doing a small baby unit. 15 people were still working on positioning, preventing deformities, cycled lighting, sound, music, and they wanted more OT consults. So I feel like if you look at this list and you see yourself and your unit on this list, I just want you to know you're in good company, right? A lot of units are working on this. And this is from over 100 people who've completed the survey. So some of the things that you guys talked about from personnel, lack of acceptance, we've heard that today, staff culture, staff stuck in their ways, busy units, no developmental team, no staff buy-in, and lack of funding. These are real realities, right, of our units. I also want you to remember, as you do go to create change, that you have to remember this innovation adoption life cycle. You have to remember that there are some people, those early adopters, those innovators who are super excited about every new thing that comes to the unit. That's me. I'm always excited about something new. We have a lot of people in the middle who are going to just wait and follow. Whatever the majority does, they're just going to follow along. We have some skeptics amongst our teams, people who've been there a long time, people who are just not really that motivated for change. We have a lot of these in our unit, and we have to just realize it's a reality. We have those who are the holdouts, right? They're the ex-skeptics. They're the laggards. They're going to wait until the last. One of the places I worked, we have one nurse who I've been doing this classes, and she's been saying, I'm going to come to your very, very last class. I am not going to do anything. I'm going to be in your last class. I'm like, okay, I'm so excited. I'm so excited to when I see you to be at that class. But she's just not doing it, not doing it. So I think it's important that we focus then. So let's look at what this really looks like in a real life NICU. We need to focus on those early adopters. So if you have a staff of about 30 people, then that means there's going to be about 5 who are the early adopters who come along with you on this new project. There's the early majority and the late majority. So if you add the early majority with your early adopters, that's about 15. That's going to get you to almost half of your unit. You see these 5 over here, these laggards? They're never, maybe never, going to come on board with you. If you focus all of your energy on trying to convince this last 10 to 15%, you will feel so defeated. Where I want you to focus on are these early adopters and this early majority. And look at your numbers. If you're from a big unit, I was just talking to a nurse from a hospital, they have 400 nurses. So, you know, she has to double these numbers. So she's got just as many laggards as she has early adopters. The laggards are noisy. They tend to have seniority. They tend to be noisy, and they tend to talk a lot. And so we tend to focus on them. Like, we feel like we need to convince them. We have to convince them. But what I want to just invite you to think about is recognizing these early adopters. Find them, partner with them, know that this early majority is going to come, then the late majority, and then maybe those laggards. But if you can get this good 80 to 90% of your unit, that's a victory. And I think a lot of times we focus on these negative Nancy's that are in every unit, right? So when we put together our team, we need to think about that. We need to think about who should we be inviting. And we also know that this is not, and we talked about it last time, this is not a single man game. It feels like it a lot, but we need to get everybody involved. Nursing, neurology, neonatology, family, follow-up, rehab, all of our different disciplines. We need everyone involved, especially that emotional support through social work. We have to have all of these people involved. So as you think about where you are now and where you're going, I hope that you downloaded the little workbook, because in the workbook, I do give you some handouts. And what I want to talk about for just a couple minutes is some research and QI stuff. So QI is really about getting from where you are to where you're going and measuring that. So bridging the gap from the care you should receive, which is evidence-based, and the quality of care patients do receive. And that's that gap, where we are, where we want to go. So despite evidence, which is this gold standard of what we should be offering, variance exists. So I love this picture because everyone was shown the same picture that they were supposed to be emulating. And even with the most amazing guidelines, there is variance in practice. We have to measure that variance. We have to figure out whether or not it's okay or whether or not we need to correct. But variance will always exist, but we just have to be able to explore it. So when we're translating and translating evidence into practice, when we're trying to look forward to what we can do to improve practice, I want to give you 3 pitfalls to frame this idea of translational research. So first off, there's the idea of underuse. So there's an amazing article that was written by Joan Smith, and she talked about using hypothermia, therapeutic hypothermia, as a model for this translation. So underuse, we know what babies should be getting cooled. But is every baby who should be cooled getting cooled by 6 hours? If not, that's underuse of a particular therapy. So underuse, not offering cooling to every baby. The other would be just what we were talking about earlier about pain. You have sucrose, you have sweeties, you have it in your Pyxis, you have it in your Omnicell, you have it at the bedside, but it's not being used. It's a therapy that's been proven to be useful, but it's not being used. Underuse of a therapy. Then we have overuse of a therapy. We give sucrose to everyone in some units. Every little whimper, every little cry, every little NAS baby, every little anything a baby gets, sucrose. What about offering cooling to babies who don't meet the criteria for cooling? We'll talk about what criteria is later, but for the most part, right, 36 weeks or above, less than 6 hours of life, pH of this, poor exam, event at birth. When we overuse something just because we think it's good, like a little bit's good, a lot's better, overuse, providing unnecessary care interventions without evidence-based benefit. So are we offering treatments that are not evidence-based, or are we offering evidence-based practices but to kids that's not really how it was designed? So overuse. So we have underuse, overuse, and then there's misuse. So just totally just using things incorrectly. So here's the article, Joan Smith, as I was mentioning, Ensuring Quality in the NICU, Translating Research into Appropriate Clinical Care. It's an amazing article. Highly recommend that you pull it and read it. It's a great discussion. And you can think about so many things in our unit. Kangaroo care, right? That's another great one we talked about today. Underuse, overuse. How about for a term kid who's there for 3 days, rule out sepsis? Are you offering enough skin to skin? Again, just things to think about. Other things that you said related to practice. Things that you're concerned about. How to decrease stim for sick babies. Noisy environments. How to teach parents effectively. How to transport HIE babies. Poor communication between OTs. Providing cycled lighting. How to read aEEG. Low experience on your transport team. So when you go to measure your practice, make sure you're using the right tool at the right time, the right person, the right matrix. We have to measure our practice in order to really know where we are and how we can move forward. So I want you to think about and write down, you don't have to share it with me, but what's your number one? What's the number one thing you want to see change in your unit? Is there something that you can implement in the next 90 days? And then think about what's that thing that you can implement over the next 9 months? We can accomplish a lot if we just put focus on one thing, just for a short amount of time. So I want you to think about what would be the number one thing, and this is where I was saying if you downloaded the little workbook that we provided, it's in the download sections inside the course. You can think about this. We gave you some worksheets of things to think about what's your number one. And you can think about all 4 domains, whether it's neuroassessment, neuromonitoring, neuroprotection, neurodevelopment. What's your number one? And then from there, then think about what are the next steps for that. And from NANT, I borrowed this amazing focused action blueprint, FAB. And what this says is give yourself a goal and give yourself a deadline, right? If you just want to improve X by X amount of time, you know, it's not enough, right? We have to give it a deadline. We have to say, okay, I'm gonna improve kangaroo care. All right, what's that mean? What part of kangaroo care? And by when, right? So give it a deadline. Determine the first 3 tasks to accomplish first, and then think of more tasks after that. Think about collaboration. You can't just change something by yourself, but what's that next thing you can do? You have your goal, you have your deadline, you have your task, but who do you need to contact? Do you need to set a meeting? Do you need to send an email? Who do you need to talk to in order to make this happen? That would be your planner, your program planner, and then you can break it down into monthly. So again, your deadlines, your tasks, and what meetings you have that are going to move you forward, and then maybe some other conversations that you might need to have. When we're creating change, there's a lot of things we have to do that make us uncomfortable. So we need to move this thing forward, and it's change and it's uncomfortable. We have to have a conversation with someone who's not following through. We have to enlist our management into this. And so there's a lot of things we have to do that get us outside our comfort zone, but that's really what helps move us forward. And I always want you to remember, like I said earlier, is focus on your success. Little baby steps are better than no steps. And then rather than aiming to be perfect, just aim to be a little better than you were yesterday. That's the only way, again, those small steps that move us forward. So just to wrap up this section, and then we'll do a deep dive for those of you who want to stay on for more about cooling. Final thoughts are, brain injury is a reality for many babies in the NICU. The brain is the organ that is the greatest impact for the greatest quality of life and function. So we need to focus on this. We've been worried about lungs, we've been worried about hearts for a really long time. We have to focus on the brain. We have the opportunity with all of these ideas to improve the quality of life for our babies and our parents too. And the quality of care that we provide through the expansion of new technologies, right? Translating all these things that we've been doing research on, we want to translate those into new practices. And really my final thoughts before we take our little break is more collaboration with neurology. I love the model that UC San Francisco's given, this co-management model. They integrate neurology into their day-to-day decision-making. They have standardized, they have an amazing article about their Neuro-NICU program. They've standardized their approach to care. Standardization, it doesn't matter what the standard is, if you standardize, it always improves outcomes. So standardizing that approach, so whether it's monitoring, imaging, follow-up, referrals, it doesn't really matter. But if you have a standard, it gets followed more closely. Parent involvement, skin to skin, holding, even when we're monitoring with these neuro monitors, we can't do those things and we can't just be monitoring babies and not having families hold. The other thing that we need to think about, and we'll talk about it in the cooling lecture, is a little bit about caregiver fatigue. These are sick babies. And if you start taking on more neuro babies, they're sick sometimes. We know this. And that the caregiver fatigue is very high for this population. I just want you to realize we need to care for each other, to be more kind, to offer people breaks, to do good debriefs, and to offer that support for each other. And then just one of my favorite quotes, actually this is one of my quotes. So everything we do in the NICU, if everything we do in the NICU affects the development of the brain, then shouldn't the development of the brain direct everything we do in the NICU? So everything we do affects the brain. And so we have to rethink some of the way we've been doing care to really be putting the brain first. Please contact me if you have any questions at all. I want to make sure that you get all your questions answered. And thanks for hanging in there. We do have one more presentation for those of you who are going to hang on about cooling. But for now, I just wanted to say thanks for those of you who might have to go. And just thanks for being with me today.
Well, everybody, that wraps up week 4 of Every NICU is a Neuro-NICU. And you maybe heard me mention that there's a deep dive into therapeutic hypothermia. So I do want to direct you to the link in the show notes where you can get access to that bonus session. All you have to do is click the link, sign up, get the workbook, get all the replays from all month, and you'll get the bonus of our therapeutic hypothermia deep dive called Mattress to Monitoring. We cover everything from initiation to a little bit about pathophys and beyond, and really focus on those bedside nursing cares that we can do to augment and to improve the outcomes of our babies and their families during therapeutic hypothermia. So go ahead, click the link in the show notes below. I hope that you've enjoyed this entire series, and don't miss next month where we have a whole new group of lectures that we're bringing to you. If you haven't already, do me a favor, go ahead and click the subscribe button here on this page. It really helps us, and it helps YouTube to know that you want to see more videos from us. I hope you have a great week. This is Kathy Randall. Thanks again for being here, and we will see you next time.